I'm Dr. Raul Tibes. I'm a consultant and the director of the Acute and Chronic Leukemia program at the Mayo Clinic in Arizona. I'm also an assistant professor at the Mayo College of Medicine and a scholar of the Leukemia and Lymphoma Society. Welcome to this case-based e-learning activity. This is the case number 3 in a series of 3 cases. I will be discussing with you today a case of an elderly AML gentleman and share some key data and insights that I hope will help you provide some outstanding clinical care to your patients in similar scenarios. It's a very pleasant gentleman, Mr. E. I met him approximately a year and a half or 2 years ago, or maybe even a little longer. He was a 76-year-old male at presentation when he came to my clinic. He was a retired architect. He was a widower. He had 3 healthy adult sons who lived close by within 50 to 100-mile radius. He never smoked, occasional social alcohol use, no drug use. In terms of his past medical history, he had hypertension, coronary artery disease, hyperlipidemia on statins. He had osteoarthritis. His family history was negative for cancer, and specifically there was no hematological blood disorder or hematological cancer in his family history previously. At the initial presentation and the initial workup, when he saw me in clinic first, he told me that approximately a year earlier, he was diagnosed with some mild anemia by his primary care physician, mildly macrocytic, as you can see there, also a borderline thrombocytopenia. His PCP advised him with observation and repeated blood tests in 6 to 12 months. Then he didn't follow up until a year later, and 2 weeks prior to seeing me to the referral, he was seen by his PCP for his annual follow-up again. At that time, he was found to be moderate to severely anemic with a hemoglobin of 8.8. You can see the white count was reduced. At the initial blood tests, it was 2, and later the repeated blood tests before he saw me, his WBC was 1.5. And he was neutropenic with an ANC of 0.34. His blood blasts in the 2 weeks prior to seeing me ranged from 30 to 40%, and his platelets also had dramatically dropped. And that initiated the referral to a hematologist. He was seen in our AML clinic. So when a patient like this is seen by a hematologist, obviously we knew from the peripheral blood that there was a high blast percentage, unfortunately indicating towards this being an acute myeloid leukemia, and that blasts were actually myeloblasts by the flow cytometry. On the bone marrow biopsy, the gentleman had 55% myeloblasts. The cytogenetics, conventional cytogenetics, and FISH panel showed a monosomy 7, that is a loss of one arm of the long arm of chromosome 7, as well as an 11q23 translocation or rearrangement by FISH as well as conventional karyotyping. Mutational testing for FLT3, both the tyrosine kinase domain as well as the ITD were negative. c-KIT, NPM1, CEBP alpha mutations were all negative. And I should highlight those 4 are the important mutations we test for at presentation for many patients. There were also some underlying dysplastic changes in all 3 hematopoietic cell lineages on the initial bone marrow evaluation and pathology, consistent with a previous unrecognized myelodysplastic syndrome. His cardiac evaluation showed ejection fraction of 49%. Performance status was still fairly good, some mild fatigue, ECOG performance status of 1. And initially, he did not have, or in his past medical history, there was no significant impairment in his renal function. However, he had some mild renal insufficiency when he saw me in clinic with a creatinine of 1.6. So the first question I have when I see this gentleman, Mr. E, at presentation approximately 2 years ago, what to treat this gentleman with? Is it an induction, a cytotoxic chemotherapy, with any of the combination chemotherapies, such as 7+3 or other conventional cytotoxic inductions, given for 2 to 4 cycles, including consolidation? Should the gentleman undergo a cytotoxic induction chemotherapy in the hospital and then proceed to an allogeneic stem cell transplantation if a donor is available? What about the choice of a low-dose subcutaneous cytarabine or ARC, 5-azacitidine plus lenalidomide, so a combination of a hypermethylating agent together with an IMiD lenalidomide? Or should the patient be treated with decitabine at the dose you can see for 5 days? And I should say the answer is, in my opinion, what is the most appropriate answer. I would say decitabine at the dose of 20 milligrams per meter square for 5 days. And why, I will lay this out in the following slides. Before I come to some of the data, there are a couple of overarching questions and variables I have in my mind if I see a gentleman with his presentation and scenario. The first is the patient fit for cytotoxic induction chemotherapy, i.e. 7 plus 3 or 3 plus 7, that's cytarabine plus daunorubicin, or idarubicin plus cytarabine, or any of those combination chemotherapies. That depends on the age of the patient, but not just so much the chronological age, but also the biological age. The comorbidities, he had some very borderline to normal ejection fraction, some mild renal insufficiency, which could have just occurred in the acute setting after being diagnosed with AML. His performance status was good, and overall his organ function was also good. So yes, he probably would have qualified for cytotoxic induction therapy despite his age and with his rather minimal or normal comorbidities. Probably the more important question is, if we admit a patient to the hospital for a month or longer and we start cytotoxic chemotherapy, what is the chance of cure with chemotherapy for such a gentleman with this presentation? And that is mainly determined by the cytogenetics molecular risk group stratification. So a cytogenetics showing a monosomy 7, the 11q23 translocation, which are generally intermediate or unfavorable cytogenetics. Also, this being a secondary AML with a documented previous history of some mild anemia, but clearly some dysplastic changes on the bone marrow biopsy, likely put him in the secondary AML category arising from a low or previously unrecognized MDS. The chance of cure for such patients is very low with chemotherapy alone. While remission rates can be high, the relapse within a year is very high. So overall, I would say the chance of cure is less than 5 to 10%, despite induction and several rounds of consolidation. Which brings me to the last big bullet point. Does the patient need an allogeneic transplant to achieve the cure after induction? So for this gentleman, secondary AML, unfavorable cytogenetics with a monosomy 7, as well as an 11q23 abnormality, we generally deem those patients incurable with chemotherapy. Thus, at the beginning, at the start of the presentation and evaluation, I do need to consider if the patient would qualify or would be interested for an allogeneic stem cell transplantation. This gentleman was elderly. Although he was in good shape, his social support was good. After discussion with my transplant colleagues, at the age of 76, we deemed that he would not be a good or ideal candidate for a transplant. And I may add that being a candidate for cytotoxic chemotherapy does not equal also being a candidate to undergo a subsequent allogeneic stem cell transplantation. I think that's important upfront to recognize this in the management of those patients. So some alternative low-intensity regimen in elderly AML patients. We can use Vidaza at 75 milligram per meter square, the approved dose for MDS, for 7 days, or the community sometimes 5 days are given, of 5 days, 2 days off the weekend, and then 2 days on Monday and Tuesday again. Decitabine, most commonly used at 20 milligram per meter square for 5 days. 10-day regimen of decitabine are being explored and may yield some very good response rates as well. Both 5-azacitidine or decitabine can be given in combination with a novel agent. Trials of a novel hypermethylating agent are appropriate as well. For example, the SGI-110, which is this cytabine prodrug. Essentially, this drug has a longer half-life and a higher pharmacokinetic exposure. At the end, the patient gets the free decitabine. And several presentations have been given at different meetings. There's a trial we have available here at the Mayo Clinic, and this is just one example of 5-azacitidine plus the Hedgehog pathway inhibitor, which is actually a smoothen inhibitor, which is called erismodegib. So you can fill in any of a novel targeted drug in combination with Vidaza or decitabine as an appropriate treatment option for elderly patients, as long as they get the standard Vidaza or decitabine. This is probably also illustrated in the next bullet point. Other clinical trials should have a hypermethylating agent backbone. There are some options in some countries to give low-dose subcutaneous cytarabine, either 20 milligrams daily, once or twice daily, fixed dose. Some would give it 10 milligrams per meter square for 10 to 14 days, and obviously best supportive care by itself or in combination with any of the above treatment choices. Best supportive care, antibiotic prophylaxis, treating infections, transfusions, pain management, psychosocial support. Why would it be appropriate, on the next slide, I want to show you why it would be appropriate that a gentleman like this could be treated with Vidaza or decitabine upfront. This is just one publication, as you can see, published a few years ago, essentially showing that chemotherapy or epigenetic therapy has a similar outcome in terms of overall survival at the top graph, as well as relapse-free survival at the bottom graph. And if you look at the table to the side, you can see the table is broken down by poor risk. The top part is chemoepigenetic. CRP means complete remission without incomplete platelet recovery. This means after the absence of leukemia, after complete remission is achieved, there's no full recovery of the platelet count. As you can see in the poor risk cytogenetic, the CR rates are 28 and 26% in the chemotherapy and epigenetic groups respectively. Very similar. And the median overall survival, unfortunately, very short for both groups, but they're the same or better in the epigenetic group. And our gentleman with his monosomy 7, a monosomal karyotype, is unfortunately an unfavorable risk factor as well, including his secondary MDS. In the intermediate risk cytogenetic group, you can see the response or this complete response rates are higher with chemotherapy. However, the median overall survival is not different. Therefore, for a patient that is not proceeding or is not interested in proceeding to a stem cell transplantation after induction chemotherapy, especially if the patient is elderly, upfront, lower intensity treatment with a hypomethylating agent is an upfront treatment option. On the next slide, you can see just some additional data from some of the larger studies. There was a study with 5-azacitidine, the AZA 101 study. If you can see, it was published down there in the JCO a few years ago already. And you can see the decitabine study, which was a large randomized trial, close to 450 or 460 patients. And this slide should just illustrate the CR, CRI, or PR, which is partial remission rates, with hypomethylating agents. And LD-ARC means low-dose ARC. As you can see, 17 to 18% of the patients achieve a complete remission with insufficient count recovery or partial response on either Vidaza or decitabine. The low-dose ARC can have responses up to 8, in some studies even up to 15% complete response rates or CRI rates. So low-dose ARC is an option. It's often given in Europe more than in the United States. The median overall survival, as you can see, for Vidaza was 25 months. It was 16 months with the low-dose ARC, and the decitabine study was 7.7 months. The trials are not comparable because the first study, the AZA 101, the study in blue, the patients had lower blast counts and had probably less a proliferative phenotype of their AML. In the decitabine study, which is highlighted in red, the overall survival benefit was not significantly better, although numerically it was 7.7 months versus 5 months. It should be highlighted that there was some, in a post-hoc analysis, there was some advantage of decitabine in elder patients above the age of 75, de novo AML with higher marrow blasts above 30%, and in the intermediate risk cytogenetic group. So my personal perspective in terms of which patients to treat with a low intensity treatment, many older patients above the age of 75, some would argue most patients or many patients above the age of 70 may be appropriate candidates. In the 60 to 70 or even 60 to 75 year age group of patients, if the patient is not clearly, or if the patient is not an allogeneic stem cell transplant candidate, does not want to undergo induction, especially with unfavorable cytogenetics, secondary AML as our patient, the previous MDS, MPN history, and so forth, strongly one could consider a low-intensity regimen. Similarly, with a very bad cytogenetic risk group, as I mentioned, and I showed you the data about the outcome of hypomethylating agents in that patient group. One question that often comes up is which hypomethylating agent to use. I think to date we do not have the firm answer and conclusion if Vidaza or decitabine are better. So on a trial, either as a single agent or in combination with a novel targeted drug or any other novel drug. I think Vidasa or decitabine are both options. In patients with more than 30% blasts, maybe decitabine, as it could be more cytotoxic. This is based on the JCO study from 2012, led by Kantarjan. Decitabine had an advantage in the elderly patients above 75, higher blast count, intermediate risk cytogenetic group. The Vidasa benefit was seen in the patient in the ASA 101 trial population. And that's important to note because those patients had a blast count of 20 to 30%. Because at the time that study was conducted, those patients with 20 to 30% blasts were actually still considered MDS. So the ASA 101 trial, this patient population could or had a little bit lower proliferative AML with a general lower blast count or percentage. However, both choices, Vidasa or 5-azacitidine and decitabine, are options in this setting. What happened to our gentleman, Mr. E? He was doing well the first couple of months. After approximately 5 months, he was started on decitabine. After approximately 5 months, he had an initial response. The white count increased. The ANC increased. He was still mildly anemic, but didn't require transfusions anymore. And his platelets came up to his pre-diagnosis platelet count around 110, 120 range. A marrow after 6 cycles showed he had 2% marrow blasts. He had 2 metaphases, still had the monosomy 7 and 11q23 translocation. Similarly, on the FISH panel, we found some low-level monosomy 7 and the 11q23 in 12.8 and 14% of the cells, respectively. The patient was doing very well for approximately 18 months when he developed progressive cytopenias, indicating an impending relapse of his AML and loss of the control of his disease by decitabine. Eventually, after 20 cycles on decitabine, a repeated bone marrow biopsy showed 18% blasts. What would you do next at that point? Treat with 5-azacitidine, admit to the hospital and start induction therapy, continue decitabine, hoping he will respond again after a few cycles, or consider a clinical trial that's based on the molecular understanding of AML in 2014-2015, for example, with a .1L inhibitor, EPZ5676, which is currently in clinical trials, specifically for patients with 11q23 chromosomal abnormality. I would say options at this point would be to treat with 5-azacitidine or consider a trial based on his cytogenetics, the 11q23. What is some of the data? As you can see in the table, there are 3 larger studies from the Moffitt Cancer Center. The GFM is the French group, as well as the MD Anderson Cancer Center, ranging from 150 to several hundred patients. This is after 5-azacitidine failure, and you can see the AML progression. What's most important at the end, the last two columns, the median overall survival is from 4.3 to 5.8 months, and the overall survival at 12 months is in the range of 25 to 30%. So the outcomes, the median overall survival is less than 6 months, less than half a year. Very dismal. This is another slide showing you the graphs of the outcome after 5-azacitidine from the French GFM and the ASA 001 study, the earlier study I mentioned. As you can see, in the darker blue, the allogeneic transplantation group had the best outcome. The lighter greenish curve, the next on top, is the investigational therapy, so any investigational therapy. Intensive chemotherapy in gray, low-dose chemotherapy in light blue, best supportive care unknown, at worst outcome. And the median overall survival, likewise for those therapies, is in the range of 4 to 7 months, up to 9 months with chemotherapy. This indicates that treatment outcome for patients after failure is low. We can see that only 37 out of 165 patients were able to make it to a salvage chemotherapy and then a transplant eventually. So most patients do not qualify for chemotherapy and transplant. And chemotherapy was not better than giving an investigational therapy in this fairly large study. What is the data for giving decitabine after 5-azacitidine failure or vice versa in this situation, giving Vidasa after decitabine failure? Responses are seen in several papers. The response rates range anywhere in the broad range from 0 to 20%, maybe a little higher in some papers. But the responses we see are mostly methodological improvements, stable disease, Some recent paper reported some possible complete remissions or near complete remissions. However, overall, the outcome is still very unfavorable. Thus, one of the papers concluded that the use of decitabine in such patients who failed or progressed after azacitidine cannot be recommended, underscoring the need for novel strategies in this setting. And I think this is the common belief for most physicians in our field, that yes, you can give the alternate or opposite hypermethylating agent, but it's also well accepted to put a patient in a clinical trial after failure of the first hypermethylating agent. For example, with the EPZ5676, this drug is a small molecule that inhibits the DOT1L. DOT1L is a methylase, putting methyl groups on DNA. We know the hypomethylating agents, like Vidasa or decitabine, take methyl groups away. So essentially, it's trying, or this medication, EPZ5676, it's in clinical trials, in phase 1-2 clinical trials. It's trying to alter the methylation of DNA. And this DOT1L enzyme is very specific to the 11q23 abnormality. As you can see, these are the responses from the phase 1 trial, which were just reported at ASH 2014 in December last year. Responses were seen in patients with MMLR, that's the MML rearranged leukemias, which is the gene that is rearranged at the 11q23 breakpoint. So the 11q23 is the MML, the mixed lineage leukemia gene in the broadest sense. As you can see here, 9 patients responded out of 34 patients who had this specific MML or 11q23 abnormalities. 2 CRs were observed, partial responses. Of course, we would wish that the responses were higher, but this is a proof of concept that molecular targeted treatments based on cytogenetics or molecular abnormalities in the patient's leukemia can work. And fortunately, we have more and more of those medications available. This is just one example you can see. There are side effects involved. We saw some QTc prolongation, fatigue, dyspnea, PR prolongation. So those drugs are obviously not approved, but they're available on clinical trials, and there are other medications available as well. So in summary, I would say the cure rate for secondary and unfavorable cytogenetic risk AML, especially elderly patients, that the response rates and the cure rates with chemotherapy alone are very low. If patients are older, anywhere above the age of 70 or 75, if they're not transplant eligible, the outcome with low-intensity hypomethylating agent-based therapies are similar compared to chemotherapy. In the age group of the 60 to 70, obviously, if a patient is an induction candidate, is a potential candidate for an allotransplant, I think those patients should undergo induction chemotherapy and evaluation for transplant as the only possible cure for secondary and high-risk AML. I think it's important to note that we group AML and we risk stratify AML by cytogenetics, but increasingly by other mutations and genomic markers and molecular alterations. And every week and every month, we have several papers coming out and understanding and learning more about the genetic and molecular makeup of leukemia. What has been missing so far over the last several years and decades is having appropriate medications for these genetic abnormalities available. I was just showing you one example. However, for example, FLT3 inhibitors have been tested widely in the clinic. I test most or all of my patients that relapse with AML for FLT3 mutations, even though they were negative at initial presentation, because a significant percentage of patients may develop or may acquire a FLT3 mutation at disease progression, and FLT3 inhibitors have shown good response rates. I showed you the data for the DOT1L inhibitor or EPZ5676. Another promising agent out there are IDH2 inhibitors, also showing significant response rates in early clinical trials. And I think it's important to keep molecular analysis and profiling of a patient's leukemia at progression in mind, because we have more and more molecular targeted therapies available. And testing for those is appropriate. If they can't be done, or if it's difficult sometimes to obtain them in the community practice setting, there are several cancer centers as well as commercial labs available that offer those tests. With that, I would like to thank you for your participation. I would like to invite you to participate in the other case-based activities in this e-learning series that are coming soon. For example, 2 other cases in this series, which are on mantle cell lymphoma, presented by Dr. Schutzmann, and multiple myeloma, presented by Dr. Niziewski. Thank you very much for your participation and for your attention today.